Thank you for the invitation to this convention, Ilya. Great honor to be here. Great to follow a great company like Centerix. Today, I want to share with you a little bit of what we're doing here at Longevity AI. I'll start with something classic of how we view the world of longevity. I'll do this quick because I guess this is the audience. I'll share then some about the algorithm. But what I'm most excited to share about, which will be the second part, is how we're scaling longevity today with private and very soon public clinics in North America. Okay, I'll start by sharing the screen. And if anybody has question, even in the middle, feel free. The best thing is to make it a conversation, in my opinion. So a little quick recap of how we view the world of longevity. So we all know the world is getting older and it's happening at an accelerated rate. We know that our unhealthy years are growing and they don't match how much medicine has advanced our lifespan. When we look at the data from the CDC in the United States, we see that over 80% of unhealthy years are the chronic aging conditions, which are all of us are familiar with. But what we also saw is that we're actually looking at longitudinal data, and this we're doing with Maccabi and Clalit, and also with the North American partners. We're seeing that the biomarkers are detectably deteriorating even 20 years before we can see the condition. And this should not surprise anybody here. Our take on it is always starting with conventional medicine and then improve from there. So when we asked our data partners, how would they suggest looking at the biggest skill of their heart? They said the Framingham score. But with the same breath, they said, yeah, well, it's the golden standard learned in medicine school. We don't trust it. So I asked them why. They said, well, done 50 years ago on one village population in the States, half smokers, not ethnically or gender diverse. And this is still the way to assess the heart, according to modern medicine, for everybody in this convention. So we said, okay, how about instead of diabetes, yay or nay, like Dr. Moss before me shared about continuous glucose monitoring, that's indeed the way. The approach is to build models with more information and therefore reduce the error range. So from the Framingham score, which was more wide, now we have more predictability and accuracy to understand what delta in which biomarker can provide extra health years. And this we did for all the bodily systems. So we have for cardiovascular disease, we calibrated for age. So it's the heart age and then the metabolic age for diabetes and obesity, immune age, cognition age. And this is for us just the first half of the puzzle, right? The second half is how can we actually get people to change their minds? Because until we're becoming a mouse, at this particular moment in time, this is the best that we have. We have, of course, GLP-1 drugs and others, but there's no doubt that healthy lifestyle and changing how we behave and even taking drugs regularly is a behavioral change. So we do the best fit between biomarkers that we want to influence and the healthy habit that we think there's a good chance that person would like to do. So we're building it on top of EMRs, genetic labs, biomarkers, and on the other hand, information from the wearable, from Apple Health, Google Health, that connects in turn to Nike, Headspace, etc. And we see previous behavior and trends and what could be a great fit. And of course, the impact to us in the convention is obvious. If you intervene early, you can detect and prevent. We have 3 products, and this is how we deliver longevity at scale. The first one is the algorithm. The second one is a dashboard for medical teams, now live in Dubai, Canada, and the United States, and the app for the members of those clinics. Okay, so I want to show you just a little bit about the algorithm, and then the title of the talk is how do we deliver it at scale. So I'd like to show you the dashboard for medical teams. Okay, So we talked to experts in their field and in the aging conditions in behavioral science, and we asked them, how can we have one conversation? You all study different methodologies, but we want to have one conversation regarding healthy years and health span. So, they said, let's look at all the incoming data. These are all the blood biomarkers that were ever connected by evidence-based medicine to the aging conditions. These are all the genes, starting from the 75 ACMG genes, American College of Genetics and Genomics, clinically valid across the world, but also whole genomic sequencing for clinics who charge, $20,000, $25,000 a year, not in the public system. Wearables. We work with Apple and Google and Samsung to get raw data from the devices. We understand the error range per metric, so we can draw trend graphs which are statistically significant on evidence-based medicine biomarkers, bringing them to the physicians. Usually, it's a big differential for them in the system. Social determinants of health, everything which is not in my control, my physician's control, but I should really do the 150 minutes suggested by the CDC to prevent my diabetes because I'm pre-diabetic, let's say, for example. But if I don't have a gym next to me, or if I never went to the gym from what I can see from my phone, from my watch, this has very little value to give me this advice. And most importantly, behaviorally, if I say no to the first advice I get from my physician, the chances that I will listen to the second one drop significantly. So the behavioral element of what is a great suggestion for me right from the top is super important. So maybe I did walk 8,000 steps a day, and now I walk 4,000. And according to the Framingham or the Framingham Pro that we produce, this can be half the risk. Let's go back to a habit I just used to have. So let's take this walk, but not today because it's raining. Epigenetics, clinical questionnaire, physical examination, microbiome, medical procedures, and my personal favorite engagement. I'm a geek of behavioral science and data science. My previous position, I led the AI department in a behavioral tech, advertising tech company called IronSource. So my job was to look at billions of people, how they use their devices on a daily basis, and just predict what we can convince them to do next. So sorry for other advertisement I have tailored to you, but now I want to tailor you something which is for the best of your health span. On the right-hand side, we talk to experts on lifestyle. How can we change them in reality? So everything regarding activity, nutrition, sleep, mind, rhythm, even down to pharmaceuticals. So in the center is what I'm most excited about a data science geek is how can we predict and prevent the conditions of aging. And just like the Framingham score, also the American Diabetes Association is a global standard. But, it's not perfect. Also, here's diabetes, it's pre-diabetes, yay or nay, for example. But what we can do is we can take all the evidence-based medicine ever written from PubMed, filter everything which is not AAA, like not published on journals like Nature, not recreated in the last 10 years, or not written by authors of clinical procedures known to that country, like North America is our focus. So instead of one paper, like the Framingham score, we can do something which is more tailored to the person in front of us, if we're physicians, to the age, gender, and ethnicity of people in front of us. And chief medical officers usually say, okay, I like that because all of the clinical procedures that I use in my clinic and study in medicine school are available in this knowledge graph. And when we're doing our AI, which is predicting the risk and which is giving the result of what I can do with it, usually what happens is that it takes from things that they already know, and if not, it's from a box of evidence-based medicine that you saw. Every edge in the graph is a paper there. So they know that all the results always have reference to evidence-based medicine, and this is an example of something I clicked in the graph. Okay, I'm putting this aside. Some of you who we met already probably saw this. This is something a bit new. This is from recent months and from the clinics that we've launched. So this is how we welcome people into the clinic. I'll give you an example from our design, and then I'll give you an actual demo user from one of our clients. So let's welcome John in the clinic. We can tell him, hey, John, we're happy with your sleep. We're a bit concerned with your activity levels. From all the body systems, the heart is aging the fastest comparing to people of age, gender, ethnicity. Here are your needle movers. They're here because they make the most impact, but they're modifiable. And here are things that you already love doing. Let's just choose one of them. And it can be one of the most significant things that you can do for your health today. Now, let's go to the live system. And I'll show you a demo user that we prepared with one of the clients. By the way, if anybody has a question in the meantime, please feel free. Okay, so John here. So we see how the classic risks are calibrated for age. We can see the aging conditions and their leading biomarkers. If the physician doesn't have time, if they just have, that 1 minute, here's the combination of things that are very good for that person's health, evidence-based medicine, and also something that matches what they love doing. Cool feature, and now going to be released out of beta, is that we can have all of these biomarkers in very little time, because that's the challenge, right? In longevity clinics, when we meet physicians, they tell us, well, I love my profession, but I wish I didn't have to work 2 hours of paperwork before every patient. And I wish I could accept not 2 patients a day, I could accept 8 patients a day. So we take automatic information from electronic medical records, or you can just drag and drop a PDF of a vendor we're working with. Well Health is one of our clients. They serve every 3rd doctor in Canada, have a few hundred clinics in the US. And you can see that Florence, our generative AI, can take every piece of information from an approved vendor. And if we have vendors in the audience, which is basically a lot of longevity companies who take a specific piece of information, have a specific set of results, and want to offer them to clinics. So our generative AI can look at the results and analyze what is very important for that specific individual to eventually contribute to that biological age and to that longevity plan. And here you can see the results from this one. And this is a genetic example. And what physicians are usually most excited about is they can get that book about you. So each of us has lots of information on a setting of longevity clinic. We also do public health systems now, but it's hundreds of pages of PDFs. And in under 10 seconds, we produce a book about that person in front of us. And we can see a letter from the physician. We can see a bit about the hallmarks of aging. Doctors usually take around 10 minutes to review it instead of these 2 hours. And now with a clinic that we deployed in North America, they just scaled from 2 patients a day to 8 patients a day. The chief medicals are happy, the chief financials are happy. This is the longevity plan. Again, this is to fine tune together with the patient, nothing like doing joint work. This is all the medical history summarized, body composition, visual, where to focus the health efforts, which mainly is the risks, starting from the medical standards, but also building up everything evidence-based medicine has to offer today. And unsurprisingly, there has been some advancement in recent decades, but they've not made their official indexes, but we include them here. And we have, of course, the biological ages, which is calibration for age, the lab results. Okay, there's more to show. We do a little bit more. We also have an app, but in the sake of time, I'll pause here. And if anybody has any questions, and if not, please, as a longevity company, feel free to get in touch. Maybe one of our clinics would like to work with you. If you want to be a patient and you're in North America, please ping us. We'll direct you to great professionals. Okay, if anybody has any questions.
You started your work saying that you can do more accurate prediction than Framingham experiment. So could you say something about the accuracy of your prediction compared to the previous predictions? Like you started with the heart, so could you say something? Because I know somehow I remember the number of 8 years standard deviation for the current genetic clocks. So I want to get some numbers.
Oh, of course. So I'm a data guy as well. But just to frame what we're doing, and your question is super important, it's the heart of our studies. But I want us to frame what clinics want today in the public system in North America and the opportunity to improve that indices. What clinics seems to want today, and this is where we've taken our product, is the clinical golden standards, the Framingham score. Like it a little bit less. This is what the boards, the medical boards in those countries want to see. And what we're doing, we're curating, or in Hebrew, we're otzrim עבורם, like a museum, the biomarkers that have evidence-based medicine next to them. And they consider it a lot of value, and they also consider it evidence-based medicine. In parallel, we're working with our data partners to develop these indices, the index of the heart, of the risk. Once we publish that, I'll be happy to ping you. If you leave me your name, I'll be happy to let you know. If you want to talk offline what we're doing so far, I'll be happy to share on that as well. But we're currently have not published or using any of the new indices.
You said that the business model is B2B. You go with clinics, but what about individual or business, or let's say I have a business center, 100 people work there, like we work, and I wanted to have tools to help people be healthy while making business. So I have different needs. When you go to clinical places, you take in advance that people are sick. We want to take care of healthy people that want to improve their performance, okay? It's a little bit different than the target you took in your business. So do you have any product, do you have any ideas about this market of working with healthy people that want to have better performance, not just people that want to live longer or be more healthy?
Okay, great question. Yeah, sorry.
No, it's a difference between being healthy and live longer and being perform good and make good business, for instance. Okay?
Yeah.
Where do you take it from? This is what I'm trying to understand.
Okay. So great question. I completely agree with you, and we seem to share the same vision of improving performance and health, also in healthy people. And by the way, shout out to Arya next to you. Hi. So, you know, what we see from our clinics that they're serving mostly generally healthy people. Even if they have one of the chronic conditions of aging, the clinic and the individuals, we call them members, not patients, just for that same reason that you mentioned. They don't consider themselves sick. And we want to predict and prevent other chronic conditions that had not yet manifested. An interesting way that is not only B2B2C what we're doing, we're B2B2C because we're also developing the mobile app and help navigate that end user experience. But there's more models. Our clinic in Dubai and our partner in Canada also plan to use it for employers because you can automate that report, and some of it does not need a doctor. So there's a version of it that can be automatically produced. We don't deliver it directly to consumers, but employers can just print out thousands of those in under a minute for all their employees. If you have any other suggested business model, I'll be happy to discuss with you. But generally speaking, I think I really agree with your approach. There's so much potential with healthy people. One more note on that. Our partners in North America really care about delivering it to that annual checkup with the physician, with my primary care doctor. It's the parallel in Israel of going to your doctor and say, hey, take a general checkup on me, please, which I assume many in this conference like myself are doing. But there it's like a setting that's covered by the insurance. And in there, you're treating generally healthy people without a specific condition once a year, giving them an overview about yourself. And this is also one of the users of the system. I hope that answers your questions. If not, I'm happy to continue offline.
Okay, thank you very much.
Thank you, everybody. That's awesome.